Welcome to our ECG Masterclass. I'm Dr. Collins. All right, listen up. The heart is an electrical circuit. P-wave, atrial dipole. QRS, ventricular dipole. T-wave, the reset.
Your normal PR interval must be less than 200 milliseconds. If that interval is longer than 200 and it's constant, that is first-degree block. Second degree, Mobitz I, that's Winkenbach, is a pattern, longer, longer, longer than a drop.
Mobitz II is a constant PR with a sudden random drop. That patient needs a pacemaker immediately.
And third degree, it's total war. The atria and ventricles are completely independent. You have to know the interval, spot the drop, and save the rhythm.
Let's go.
Now, before we interpret these electrical signals, our disclaimer. This content is for educational purposes for international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions. Okay, Sarah, let's dive in. Students often struggle with the axis. So if we only look at two leads, how do we determine if the heart's electrical vector is normal? We use the two thumbs up rule, Dr. Collins. All you need are lead I and lead AVF. So if lead I is positive but AVF is negative, their vectors are leaving each other. That's left axis deviation. But if lead I is negative and AVF is positive, they are reaching for each other, and that's right axis deviation. You can spot it in 5 seconds. Perfect, quick and clinical. Now let's talk more about the AV blocks. First degree block is often asymptomatic. What's the definition? It's just a simple delay, Dr. Collins. The PR interval is greater than 200 milliseconds. That's one big box on the ECG paper. But, and this is key, every single P wave is followed by a QRS. There are absolutely no drops. Right, but when we get to second degree, things get much more interesting. So, Dr. Collins, why do they call Mobitz I the Winkenbach waltz? Because it has a distinct rhythm, Sarah. It goes longer, 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 drop. The AV node is getting tired. It's fatiguing. This is usually nodal and benign, which is why you might see it in athletes or even during sleep. For this reason, Mobitz I rarely needs a pacemaker. But Mobitz II? That's a whole different story. Exactly. In Mobitz II, the PR interval is constant, but then a QRS just disappears out of nowhere. This usually means the block is below the AV node, down in the His-Purkinje system, and that's dangerous. It's totally unpredictable and can progress to a third-degree block at any moment. So for your boards, just remember, Mobitz II equals pacemaker. Spot on. And that brings us to third-degree block, or complete heart block, where the atria and ventricles are literally not talking to each other. You'll see P waves just marching along at their own rate, and the QRS complexes at theirs. So, Sarah, what's the classic physical exam finding in third degree?
Canon A waves in the jugular venous pulse. It happens because the atrium contracts against a closed tricuspid valve. You're seeing a massive electrical and mechanical dissociation.
And that brings us to our question of the day. Have you ever diagnosed a Mobitz I in a young athlete and then had to explain that it was actually a normal finding for them? Let us know about your clinical encounters. All right, let's lock in these blocks. Ready? First is a delay.
Mobitz I is Winkenbach, longer drop.
Mobitz II is the fault.
Random drop.
Third is dissociation. More. And 2 thumbs for the axis.
Excellent. We've mastered the slow rhythms. But what happens when the heart starts racing? Well, you'll have to join us in the next module, where we take on narrow complex tachycardias and hunt for the sawtooth and the irregular.